The following podcast is part of a certified educational activity titled New Horizons for Advanced Endometrial Cancer Treatment, Utilizing Innovative Immunotherapies and Other Novel Approaches. Access the entire activity and complete the post-test at peerview.com/GEP 860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Shannon Weston, professor and gynecologic oncologist from the University of Texas MD Anderson Cancer Center in Houston, Texas. Welcome to this educational activity entitled New Horizons for Advanced Endometrial Cancer Treatment, Utilizing Innovative Immunotherapies and Other Novel Approaches. Our goal today is to explore recent advances for the treatment of recurrent and advanced endometrial cancer. We'll cover what these developments mean for patients, as well as discuss their effective implementation for multidisciplinary provider teams. We'll also take a look at future impact by bringing regimens into the frontline setting and explore approaches using novel mechanisms of action, all in an effort to improve outcomes for patients with endometrial cancer. Let's get started. So first, let's level set and talk about how common endometrial cancer is. And the bottom line is it's the most common gynecologic cancer. Across all cancer types in the U.S., it's about 3.4% of new cases, but more importantly, it provides about 2.1% of all deaths. And different from most other solid tumors, the incidence of endometrial cancer is increasing, as is the death rate. And so this is a clear unmet need for our patient population. The median age of diagnosis is 63, but you can see that diagnoses really can come along the entire age continuum, and we are seeing more and more patients diagnosed at early age. This is the way we stage endometrial cancer. This is a surgically staged cancer, and the fortunate thing is the majority are diagnosed at early stage, where they can be cured with relatively straightforward surgery as well as perhaps the addition of radiotherapy. As we get into more advanced stages, the survival does decrease. It has an overall 81% relative 5-year relative survival, which is driven by that early stage of diagnosis, but the outcomes for patients with advanced stage or recurrent disease are quite poor. And whenever we talk about endometrial cancer, we have to talk about the disparities which have been observed for patients with this disease. And if we look at endometrial cancer versus ovarian cancer, for example, the mortality rates have been increasing and are now comparable to ovarian cancer. Traditionally, we taught that endometrial cancer is more common, but ovarian cancer is more deadly. And now that simply isn't true. But even more so, after we finish comparing endometrial to ovarian cancer, when we look at racial disparities in endometrial cancer, it is very clear that the burden of mortality has really increased disproportionately among Black women. And if you look at these graphs along the bottom of my slide, you can see that patients that are Black do much worse than white women or even Hispanic women. And so this is an area where research really is, I would say, exploding to understand why this happens. And as we look at the clinical trials I'm going to discuss today, you'll see that unfortunately many of them don't have many Black women in the clinical trials. So this is an area of great need. Digging a little bit more into the data around survival disparities. So as I mentioned, women that are Black have a higher mortality than women that are white. And in the past, we used to think, oh, well, this is because Black women are more likely to have non-endometrioid type cancers that do more poorly, or they come in at an advanced stage. But when you control for these very important factors, we actually don't see that that's the only factor. So there are other potential risks that are leading to these disparities in Black women. So again, a little bit of level setting, talking about the basics of treatment. So for patients with high-risk disease or metastatic disease, stage 3 or 4, or newly recurrent who have not really received any therapy other than surgery, the bottom line is the backbone of therapy is chemotherapy, including paclitaxel and carboplatin. And this has been shown in several randomized trials, and including a randomized phase 3 trial in carcinosarcoma, where paclitaxel and carboplatin was improved survival outcomes over ifosfamide and paclitaxel. Now, in GOG 209, this was a study that compared the previous standard of care, which was called the TAP regimen, which was paclitaxel, adriamycin, and cisplatin. And that was compared to paclitaxel carboplatin. It was a non-inferiority trial, and what it demonstrated was that paclitaxel and carboplatin was not inferior to the TAP regimen, and so that really established it as the standard of care for all comers endometrial cancer. Now, recently, we've done a lot better job, and I'm going to get into this into some more detail over the next few slides, of molecularly classifying endometrial cancer, not just lumping everybody together as the same disease. And Amanda Nichols-Fader and her colleagues really are to be congratulated because they really pushed the envelope for patients with uterine serous. Uterine serous has a high proportion of aberrations in HER2. And so they looked at the addition of trastuzumab to paclitaxel and carboplatin and found improvement in survival when trastuzumab was added in patients that had high expression of HER2. So as I mentioned, we're doing better. We're learning that in fact, endometrial cancer isn't just one disease, but in fact it's many. Right now, our kind of best way to molecularly classify is using the data that were generated through the Cancer Genome Atlas, where we found there were 4 major subtypes of endometrial cancer. The POLE ultramutated, which has anywhere from 100 to 500 mutations, including aberrations in P10, as well as hypermutated, which are microsatellite instability high, often have aberrations in the Lynch proteins and genes. They see about 10 to 20 mutations, often the endometrioid type. Now, these two are so-called hot tumors, which means they have the opportunity to potentially benefit from immunotherapy. Conversely, on the cold tumor side, you can see it's driven by copy number. So those all the way over on the right, copy number high tumors tend to be more consistent with serous type tumors with P53 mutations and high number of copy number aberrations. Conversely, the copy number low typically don't have many mutations, typically endometrioid type, although we can see other cell types in this group, and very commonly have P10 and beta-catenin mutations. So the question is can we use what we know molecularly to bin tumors into these classifiers? And can we use these molecular classifications to guide treatment? Okay, so as I mentioned, the POLE and the microsatellite instability high tumors tend to be have high levels of mutations and be potentially more sensitive to immunotherapy. So identifying those patients first seems to be the best choice. Now, the PROMISE group put together a way to simply, and I put it in quotes, bin patients by their molecular aberrations. And the reason I put it in air quotes is because it requires next-gen sequencing, which isn't necessarily something that everybody has access to. But be that as it may, what you can do is you can do the next-gen sequencing to identify if the tumor is POLE hypermutated or ultramutated. Then you move forward with protein assessment, looking for microsatellite instability. And then finally, utilize your P53 testing, whether that's mutation or protein, to bin the tumors into either copy number low or copy number high. And when you do that, you can see clearly an impact on prognosis. And potentially, we may be able to guide therapy. And that's beyond the scope of this particular talk today, but it is something that's coming down the pike. And to that end, this molecular testing and classification has been included in a number of guidelines. These are the ESGO, ESTRO, ESP guidelines, where you can see that they define prognostic risk groups utilizing molecular classification. What's nice about this is on the left, you can see the kind of standard risk group classification with just pathology, just stage, just lymphovascular space invasion. So if you don't have the molecular classification, you can still bin your patient. However, if you do have your molecular classifiers done, then that may change some of the risks. Specifically, the major thing that changes is POLE ultramutated move into a low risk group because it does appear they may not need as aggressive therapy as some of the other aberrations. Similarly, the NCCN does suggest that testing and doing molecular analyses is appropriate in this patient population. And again, as I mentioned, you start with that POLE sequencing, move on to your DNA mismatch repair protein testing, and then finally finish it up with the P53 testing. Now, this is just prescriptive to do. They don't provide guidelines of how to use it yet, and that's because there are studies that are ongoing that will hopefully give us that information. So let's talk a little bit more about mismatch repair gene aberration, and specifically what we expect in endometrial cancer. So this is actually a graph that shows you a number of different cancers, and what I want to call your attention to is the uterine cancers. It's most common to see microsatellite instability high, and we see it in about probably 30% of tumors, and it is predominantly in that endometrioid type. Some of the struggles that we've had certainly have been around access to genetic counseling. The nice thing about testing endometrial cancer is this can be done at the pathology level. That early screen, you don't have to involve really anybody else. So I think some places that have been the most successful have made this an automated order. So for us at our institution, every patient who has surgery for endometrial cancer automatically gets testing of these proteins. It's built in. So there takes away that idea like, oh, I forgot to order this, or I'm sure someone else is going to do it, and that type of thing. And so when we are talking to our patients, we tell every single patient who's undergoing surgery for endometrial cancer, this will be done as part of routine testing to potentially identify if you have Lynch syndrome, and also to potentially guide your treatment in the future. And so we found that to be really helpful. Other options are to make sure you've got an advanced practice provider or staff that's their job. When they're booking the surgery, they order this, or when you're reviewing the pathology, you order it. So I think things like that, anything that can be made more automated, always helps us get it done. And so this is just a little bit more around that idea of collaborating with your pathologist. Certainly, I think many of us that are doing oncology surgery need a pathologist that understands our disease, that can make appropriate diagnoses in an efficient fashion, and communicates well with us to understand how to best care for our patients. So, if you've got a pathologist that you can collaborate with, then you can help work together to prioritize what testing is being done. As I mentioned, we do, prioritize the testing of mismatch repair deficiency, but as we talk more today about some of the other targets that are under evaluation and some of the new agents that are coming down the pike, we want to be mindful of the amount of tissue we have and what are we using it for, ensuring we don't run out of tissue and then not be able to do additional testing that might help our patient. So let's get more into the immunotherapy piece, right? So we've talked a little bit about those hot tumors, the POLE, as well as the microsatellite instability high. When we talk about immunotherapy, what exactly do we mean? So essentially, we're the bulk or the majority right now of immunotherapy, and the most active immunotherapy in endometrial cancer, is around the PD-1, PD-L1 checkpoint. Now, if you think about it, these checkpoints are like brakes on our immune system. And so when we block those brakes, when we either use a PD-1 or a PD-L1 inhibitor, that helps remove those brakes. It takes off the brakes to let the immune cells kind of run wild. The reason we talk about hot and cold tumors is you can rev up the immune system or take the brakes off the immune system in a cold tumor, and it will hide. It will not be identified by those immune cells. Conversely, those hot tumors, it seems they're easier for the immune cells to find, and that's why we see efficacy. So we've seen a number of different studies reported around single-agent checkpoint inhibition, and it does seem to be an effective strategy, but it has to be in a biomarker-selected group. So I'm going to go through quickly 3 major studies that have led to FDA approval. The first is Keynote 158, which was looking at pembrolizumab as a single agent for recurrent endometrial cancer. And importantly, this was for microsatellite instability high or mismatch repair deficient tumors that had had at least one prior regimen and measurable disease. They were treated with pembrolizumab 200 milligrams IV every 3 weeks. And the primary endpoint was response. And you can see here, spoiler alert, I think most of you have heard, it was a positive trial and it did yield an FDA approval in endometrial cancer in 2022. But we already were using this in clinical practice because we knew there was a tissue agnostic approval in 2017 that allowed us to use this agent for any mismatch repair deficient tumor. But here are the data. We saw an incredible waterfall plot with the majority of patients with some type of reduction in disease and a 50% response rate, as well as 18% achieving stable disease. Importantly, progression-free survival was very high at 13, and overall survival achieved 65 months, which was just unheard of in this disease. Now, the phase 1 Garnet study looked at dostarlimab. Now, this again was open to multiple tumor types, but they did have several cohorts which were focused on endometrial cancer. You can see A1 was in mismatch repair deficient or microsatellite instability high, and A2 was in mismatch repair proficient or microsatellite stable disease. And this was recurrent or advanced endometrial cancer. They had to have prior platinum, but they had at least 2 prior lines of treatment. So this was dosed at 500 milligrams IV every 3 weeks for 4 cycles and then bumped up to 1,000 milligrams every 6. And similarly, it did work. And so we did have FDA approvals, including a tissue agnostic approval in 2021 and an endometrial cancer mismatch repair deficient approval in 2021. And this is why. So beautiful swimmer plots. You can see some patients on for over 3 years and counting. Response rate was 45% in that tumor type that was mismatch repair deficient. A little bit less, but still some activity in mismatch repair proficient, 15%. Not quite what we were hoping for there, but as expected, because we do know that biomarker direction is the most important thing in this disease. Similarly, we saw a PFS that was quite high at 6, and overall survival has not yet been reached. So the Phaedra trial is a phase 2 trial of durvalumab, and this is again in patients with either mismatch repair deficient or proficient endometrial cancer. You can see they laid it out in 2 different cohorts. All patients were treated with 1,500 milligrams of durvalumab IV every 4 weeks, and response rate was the primary endpoint. Looks good. So again, similar to the last 2 studies, 47% response rate in that mismatch repair deficient group, progression-free survival 8 months, and overall survival not yet reached. So very consistent data across the different checkpoint inhibitors for mismatch repair deficiency, similar to the other 2 studies. Low response rate for the proficient tumors, only 3%. So a clear, I think, message that single agent immunotherapy in mismatch repair deficient disease is the standard of care. So that's only 30% of patients. So what do we do for the patient population that has microsatellite stable disease? Well, we have a combination for that. The combination of pembrolizumab with the multi-tyrosine kinase inhibitor lenvatinib has shown quite a bit of activity for patients that are microsatellite stable. And this did achieve an accelerated FDA approval in 2019 and full approval in 2021. So let's look at the data that led to that full approval. So this was the phase 3 Keynote 775 study, which was an advanced and recurrent endometrial cancer. They had to have at least 1 prior platinum-based chemotherapy and an appropriate performance status of 0 to 1, and this is important. And patients were then randomized 1-to-1 to either the lenvatinib 20 milligrams PO daily with pembrolizumab 200 milligrams IV every 3 weeks, or standard of care chemotherapy with either doxorubicin or paclitaxel, weekly paclitaxel. The primary endpoints, it was actually dual primary endpoints of progression-free survival by BICR and overall survival. And they also looked at response rate as well as quality of life, which is incredibly important with this regimen. And what they found was across the entire population, progression-free survival, overall survival, and response rate were all statistically significantly improved with the combination over chemotherapy. And this is just a snapshot of those results, but I'm going to get into it in a little bit more detail. So first, here is the overall survival benefit. You can see that they did allow some patients that were mismatch repair deficient on. So they did look at the proficient group separately, and you can see that there was a 30% reduction in the risk of death for those patients that were treated with lenvatinib and pembrolizumab, is equivalent to about a 6-month difference in in overall survival. This was also recapitulated in the all-comers group that included a minority of patients with mismatch repair deficiency. Similarly, we saw a benefit in progression-free survival, both in the all-comer population as well as the mismatch repair proficient group. You see a 40% reduction in the risk of progression in the group that was treated with lenvatinib and pembrolizumab. And then, of course, this was all consistent with an improvement in response rate. So about a doubling in the response rate, 32% response rate in the mismatch repair proficient group, almost 34% response rate in the group that was all comers. But importantly, look at the duration of response. The duration of response was 9 months, which is really impressive. The disease control rate was 72%. So nearly almost all patients had benefit from this combination. So let's talk about a case. Let's put this into context for a patient in front of us. So this is a 59-year-old woman who was diagnosed with a FIGO grade 1 endometrial cancer. She underwent minimally invasive hysterectomy with bilateral salpingo-oophorectomy and sentinel lymph node dissection. Her final pathology was grade 2, endometrioid type, stage 3C1. And we got some immunohistochemistry, and it revealed that she had microsatellite stable or mismatch repair proficient disease. So she was treated with chemotherapy. She received paclitaxel and carboplatin, and initially she had a very, very nice response. But unfortunately, 4 months after completing her first-line chemotherapy, she presents complaining of new abdominal symptoms. So we got some scans, and you can see what we found. Some disease on the liver, peritoneal carcinomatosis, disease along the diaphragm. So we obtained a biopsy, and it did confirm metastatic disease. So what are her options? What can we talk to her about? Well, let's get into a little bit more detail to decide. So first, I think it's always important to highlight we are not a paternalistic society as we're working through decisions with our patients, right? We want to engage our patients in shared decision making. The way to do that, and I love how simple these steps are. We invite our patient to participate in the decision making. We present the options, review risks and benefits, help them to kind of interpret those risks and benefits in the context of where they are. We facilitate that deliberation and decision making, and then assist with implementation. Now, when we're doing that, there are lots of things on the patient level that should be considered, right? What other medications is she on? What surgeries has she had, or is surgery an option? What are her current comorbidities that might impact the side effects that she could have? What's important to her? What symptoms is she already having? What symptoms make her worried? And what are her goals around quality of life? And then we also, of course, want to make sure that patients will adhere to the regimen that we prescribe. And so thinking through how compliant and how easily something can be given. So back to our patient. So we decided to give her pembrolizumab, right? She had microsatellite stable disease. She'd had her chemotherapy already. And this is an FDA-approved regimen that is molecularly targeted to her. So she gets about a month of treatment and then presents with grade 2 diarrhea. So this happens all the time, right? And we know this is one of the tricky side effects or adverse events that we can see with this combination because it overlaps. We can get the diarrhea from the pembro, we can get the diarrhea from the lenvatinib, and really, we want to think through how we approach the patient to handle these overlapping toxicities. So first, let's level set around immune-related adverse events. The bottom line is it's inflammation, and it can happen anywhere. But certainly there are more common places that we see these adverse events, including in the skin, where we can see rash or pruritus, the GI system, where we see diarrhea, nausea, vomiting, the endocrine system, where we can see aberrations in thyroid, and of course the pulmonary system, where we can see pneumonitis. And, the timing really matters, right? So a lot of the immune-related adverse events happen during specific time points. So earliest usually is going to be the rash or dermatitis. Then we see colitis, liver, endocrine, all kind of later in the duration. But what I want to call your attention to is the later effects. So nephritis happening much, much later. And then endocrinopathies really can happen at any time, even after treatment with immunotherapy, which is really important just to keep it top of mind as you're doing your assessment. Now, I'm not going to go through this in detail because there's a lot of great data on here, but I wanted to provide it for your reference. But just give you a sense of when we're grading these, how do we manage them? So, grade 1 is going to be minimal to no symptoms. Really, you identified it based on a test probably, but the patient feels well. In general, you can continue checkpoint inhibitor therapy at that point with some exceptions. Grade 2 is going to be mild to moderate symptoms, and for most, you're going to hold for that at least, and maybe consider steroids to help reverse that, and then maybe resume once it's resolved. And then finally, grade 3 or 4, which is severe or life-threatening. Again, definitely holding checkpoint. High-dose steroids, usually inpatient, IV. And really, this is where multidisciplinary care is so important, where we, enlist the specialist of choice, right? So if it's an endocrinopathy, get in with endocrine. If it's GI, have your gastro there, and really work together to determine, 1, can we reverse this? And 2, would we ever reconsider redosing? Now, when we get into the combination strategy using the tyrosine kinase inhibitor with immune, then you can have 2 sets of adverse event profiles with some overlapping. I love this little graph where you can see the rash, the diarrhea, hepatitis, thyroid, and altered mental status can all be potentially seen with either one of these agents. And so, one strategy that we use that I think is really important is stop the TKI. It's quick, it has a shorter half-life, and if that reverses your toxicity, then you've got your answer. Of course, sometimes if the patient is very ill, you have to bring them in. Utilizing kind of steroids and things like that is appropriate, but this is where communication with the patient is really critical, making sure that she knows if she begins to have any diarrhea, if she begins to have any rash, she doesn't want to wait until it gets really extensive or really serious, that she needs to call you immediately so that you can start, the appropriate actions like stopping the drug, instituting, basic care, things like that. But really stopping that TKI can be really helpful in identifying, because if the patient has diarrhea, like our patient, and you stop the TKI and her diarrhea continues, well, then you've got your answer. I do think the timing also, we wouldn't expect the GI toxicities for IO this soon for our particular patient. So my money is on the lenvatinib, but of course you want to be ready for either option. Now, this is just getting a little bit more into specific grading and management based on GI, endocrine, and dermatologic. You can see that there's some really nice guidelines here. So for our patient, let's look at this gastrointestinal. So if we did determine that she had an immune driven diarrhea, you can see you would grade it based on stools. And this is important. You grade it based on stools above baseline. A lot of our patients have had surgeries. They may have baseline irritable bowel, things like that. So you find out, you always want to identify how many bowel movements they have a day on a normal day, and then use that to guide what grade they are when they started the medications. With, as we mentioned, grade 1, you can continue the checkpoint inhibitor and just use some symptomatic things like antispasmodics, antidiarrheals. For a grade 2, which is 4 to 6 above baseline, you're going to hold drug and start some steroids. And this can be done orally, but it really is going to depend on the status of the patient. I think most of us end up admitting these patients because you need to give them fluids because they're getting dehydrated, and you can titrate the steroids a little bit easier when they're in the in-house. If it doesn't get better, you can consider infliximab or even vedolizumab. But this is where our multidisciplinary care really helps, to have a gastroenterology specialist who does this, who understands this, to help guide those decisions and also help manage side effects from these drugs. So I think we kind of talked through our patient with diarrhea. I think for grade 2, we would definitely want to hold both drugs, but give her a couple of days and see if she improves with just holding the lenvatinib. Give her some antispasmodics, some anti-motility agents, and if she doesn't get better, bring her in for steroids. Just a few kind of thoughts around communication. So, this gets back to what I was talking about. You want to make sure your patient is aware and understands what these regimens are and how they're different from chemotherapy. And so making sure you're educating your patient about her options, how it works, and what is possible as far as adverse events. And this is going to not only be before you start, but also kind of throughout treatment, kind of highlighting things. And if you learn new things, making sure your patient is aware. Things to emphasize, again, it works differently. It has unique side effects, and really get them to report as soon as possible. And then, there are a lot of really neat things available for patient education. So different handouts, wallet cards. You can give them medications ahead of time. So giving them a prescription for anti-nausea, anti-diarrhea medicines, and say, okay, I still want you to call me when you have these symptoms, but because it's so common, I'm going to go ahead and give them to you so that you're ready, so you don't have to suffer or wait for me. So we've talked a lot about these different immunotherapy regimens, and I think it's really important to note that right now these are second line and beyond, but more than likely these are going to move earlier and earlier into upfront care. So let's talk about a case that will help us understand what is coming for our patients in the future. So this is a patient I saw in my clinic, 62-year-old retired nurse. She was diagnosed with stage 4 carcinosarcoma. She had not received any therapy as yet, and as expected when we tested her tumor, it was microsatellite stable. She is very healthy, she is very motivated, and she has a performance status of 0. So she's ready to do whatever she could to handle her care. And so at this time, we had a number of clinical trials open. So let's talk a little bit about what might be available to her. And what's cool about this case is that, yes, these trials are now closed. They're about to read out. But these are going to be, hopefully, depending on the results, things that we'll be able to offer our patients in the clinic. So let's talk a little bit about the number of phase 3 trials that are either completely enrolled or close to being enrolled that will potentially impact this patient in the clinic. So first is the regimen that we've been talking about quite a bit, the combination of pembro and lenvatinib, and comparing it to standard upfront chemotherapy. So this LEAP-001 study randomized patients to either len-pem or paclitaxel carboplatin. And our patient would fit this trial. She was newly diagnosed stage 4. She had a PS of 0. They're looking to improve progression-free and overall survival. We like that for her. But unfortunately, this particular trial wasn't an option for her because it did exclude carcinosarcoma. Well, what about the phase 3 Keynote C93 trial? This trial is actually trying to move single-agent pembrolizumab into the front line as compared to chemotherapy, but it is for patients with mismatch repair deficient disease, appropriately, right? We know that that patient population does have a really nice benefit from single agent. So patients are stage 3, 4, including carcinosarcoma. They have an ECOG of 0 or 1. And mismatch repair deficiency. Now, our patient doesn't qualify for this trial because she had microsatellite stable disease, but certainly nice that they included carcinosarcoma here. So then the question has come, can we actually use other combination strategies? We've talked about immunotherapy with TKI, but what about combining immunotherapy with chemotherapy or immunotherapy with chemotherapy and PARP inhibitors? So this is a nice little table of the studies we're about to talk about that are trying to move the envelope forward and add something to chemo rather than replace chemo. So first is GY018, which actually just completed enrollment. This is adding pembrolizumab to standard of care chemotherapy. And this was a patient population that is advanced or recurrent, no prior chemo, or prior chemo if it was more than 12 months ago, appropriate performance status, and they're randomized 2-to-1 to either paclitaxel carboplatin alone or paclitaxel carboplatin with pembrolizumab, and they're looking to improve progression-free survival. They are looking at it in the mismatch repair deficient group as well as in all comers. Similarly, the ATTEND study, newly diagnosed, frontline, chemo-naive, or platinum more than 6 months ago, appropriate performance status, randomizing to chemotherapy with or without atezolizumab, okay? And primary endpoints are overall survival and PFS. So this might have worked for her. The RUBY study, so there's 2 parts to the RUBY study. The first part was combining chemotherapy with or without dostarlimab. Okay, so again, advanced recurrent, no prior chemo, or prior chemo if it's more than 12 months ago. They did allow carcinosarcoma, so this is a potential option for our patients. Patients were randomized and they're looking to improve progression-free survival. Now, hot off the press, there has been a press release around RUBY Part 1 that indicates that the trial met its primary endpoint of investigator-assessed progression-free survival and showed a clinically meaningful benefit in pre-specified analyses, including the mismatch repair deficient subgroup as well as an all-comers subgroup. That's all we know. We have no data yet, just this press release, but certainly very exciting, we'll have to determine how this will potentially impact our patients. I will note RUBY Part 2 is still, I believe, maybe still enrolling or may almost be done now. That is taking the next step and adding a PARP inhibitor to dostarlimab as a maintenance strategy. Now, what did we do with this patient? This patient went on my phase 3 DUO-E study. So DUO-E was similar to these last couple groups, stage 3 or 4, recurrent, chemo-naive, or had response to chemo and was off for more than 12 months, and they're randomized to 3 arms. Okay, so there's either chemotherapy alone, chemotherapy with durvalumab followed by durvalumab maintenance, or chemotherapy with durvalumab followed by durvalumab and olaparib maintenance. And this did allow for carcinosarcoma, and she still remains on therapy. So fingers crossed for her. So let's talk a little bit more. This woman, is a great example of making sure you have access to the next best therapy, right? She would have gotten paclitaxel carboplatin. Who knows what might have happened? She remains on maintenance now, and she's doing very well. And there's something to be said for the improvement of benefit and clinical benefit that we see in patients that have access to clinical trials. Now, we know we got to do clinical trials to get medicines into practice, medicines into the clinic, but you're giving patients early access too, right? So if you've got clinical trials open or you have access to a group that does, you're giving your patient a chance at a potentially more meaningful, better outcome before it gets out to everyone else. So you can see that personal benefit definitely directly to your patient with improved disease outcomes. But then also there's that idea around altruism, that you're helping others and that you're improving the care of other women by participating in these clinical trials. As I've mentioned before, I'm kind of beating the drum on this, we've got to improve our diversity in clinical trials to make sure that every single patient is represented, and so that we know that these regimens that are excellent in clinical trials actually will truly benefit every single patient in our clinic, regardless of race, ethnicity. And the only way to do that is to improve education around clinical trials, improve access, and also find out what the other barriers are. Why aren't these patients going on clinical trials? How can we overcome those barriers? So we've talked a lot about what's going on right now. But let's talk a little bit more, just spend the next few minutes talking about what is coming down the pike and see some really interesting novel agents that are being explored and showing some real promise in endometrial cancer. And this includes targets such as WEE1, ATR, cyclin-dependent kinase inhibition like CDK4/6, CDK1/2, as well as antibody drug conjugates, which have really come into fruition in ovarian cancer and are now being explored in endometrial cancer as well. Arguably one that's the farthest along is a drug called selinexor. Now, selinexor inhibits exportin, which basically is an export protein that moves tumor suppressor proteins like BRCA, P10, P53. And when you block that, it traps those tumor suppressor proteins in the nucleus to and allows them to be reactivated. This is especially important for tumor suppressor proteins that are going to help create mitotic catastrophe and kill those tumor cells. So specifically, selinexor seems to reactivate P53, which is of course incredibly important across a number of different cancers, including endometrial cancer. And we've seen activity of this agent as a single agent and now are exploring it in a number of different places. The place that's farthest along is in the maintenance setting. So this was the phase 3 SIENDO study. This was for patients with stage 4 or recurrent endometrial cancer that had had benefit on carboplatin and taxane combination. They were then randomized 2-to-1 to either receiving selinexor at 80 milligrams weekly or placebo, and they were continued on either one of these agents until progressive disease. The primary endpoint of the study was progression-free survival, investigator assessed. And they also looked at a number of other relevant secondary endpoints, including looking at molecular subclassification using P53, mismatch repair proteins, and POLE, just like we talked about earlier today. The bottom line, it worked. So in the intent to treat population, they did see a reduction in the risk of progression of about 30% for the patient population that was treated with selinexor. But interestingly, when they teased out some of the subpopulations, they saw patients with endometrioid histology seem to get the biggest benefit, almost a 50% reduction. When they teased out even more, looking at the molecular subclassification, it became apparent, although this was a subset analysis, that it did seem that the biggest benefit was derived in those patients with wild type P53. And that makes sense, right? We talked about this traps those tumor suppressors in the nucleus. So if you have a mutated tumor suppressor that's not going to work, it's not going to help you have better outcomes. Versus if you have a wild type active tumor suppressor in P53, that's where you're going to see the biggest benefit of this drug. So this is moving forward in a clinical trial just in that select P53 wild type population. And I'm hoping that all of you are opening that trial at your institutions now. Safety, of course, is important whenever we're talking about maintenance. We're keeping somebody on a regimen for years. We want to make sure it's tolerable. Overall, this was fairly tolerable. The adverse events were manageable with supportive care and importantly with dose modifications. So you did see dose interruption in about 50% of patients and dose reduction about 50% as well, but only 10% discontinued, and there were no deaths. And so this does seem to be safe. It's certainly, you need to learn how to modify and support your patients that are receiving it, but it is worth the side effect profile if they're going to live longer. Now, around that P53 target as well, this is WEE1 inhibition has been really exciting. So how does this work? So what we know is P53 is the regulator of the G1S checkpoint, right? And so when it's mutant, there is increased in replication stress and an increased dependence on later checkpoints like the G2M checkpoint. Now, the G2M checkpoint is regulated by WEE1. And so just like we see with BRCA and PARP inhibitors, we're able to have like a 2-hit synthetic lethal combination. If you already have loss of P53, and then you hit and inhibit WEE1, you see, again, increased cellular catastrophe and cellular death. And so this does seem to be a way to select a very potent targeted therapy for our patients. Now, we know uterine serous has a high proportion of P53 aberrations. And so the thought and the hypothesis for utilizing WEE1 inhibition in this disease was to kind of take advantage of that dependence on the G2M checkpoint in that particular cell type. And what we've seen so far is this hypothesis is correct. So adavosertib is a WEE1 inhibitor that was explored in only uterine serous tumors. They did not select by p53 mutation. They just tried to select by the histology type. And what they found was the response rate was about 30% in a pretty heavily pretreated group of patients with endometrial cancer. And importantly, 47% of patients were alive progression-free at 6 months. So very exciting data. And certainly, again, we do see toxicities with these different inhibitors. And the majority of patients actually experienced at least diarrhea, fatigue, and nausea, but they could be managed with supportive care, and the majority of patients did stay on trial. So, I think we've covered a lot of data today, and certainly have seen a lot of really exciting things that are either available now or are going to be available to our patients over the next few years. So as these choices expand, it's going to be really important for us to maintain connections and collaborations with our multidisciplinary and multi-professional team in order to be most effective with our patient management. So let's talk a little bit about the role of the wider clinical care team in supporting our patients. And so we know in our team, it's not just us, right? We can have advanced practice providers like physician's assistants, NPs. We have nurses, we have pharmacists, we can have genetic counselors, pathologists, really work together as a group to understand what we're doing, what are these mechanisms of action of the agents that we're using, help kind of get out in front of the potential adverse events and problems that patients might experience, and maybe prevent and at the very least educate our patients around the potential for these adverse events and how to mitigate them. We also bring clinical trial expertise to our patients. We facilitate communication. I think I mentioned multiple times when we were talking about the immune-related adverse events, how I love getting other groups involved, derm, GI, endocrine, get them all involved to help how your patient have that best outcome. And then, of course, refer your patient for appropriate support services. So this conclusion slide is full of data because we've covered a lot over the last hour. The bottom line is, we previously did have limited treatment options, but now we're seeing those options expand, and I expect over the next few years to have a huge array of options for our patients. We know that this tumor is increasing in incidence and mortality, and so there's still a lot left that we need to understand and a lot left we need to do to overcome this disparity among the tumor itself, and then also the racial disparities that exist within endometrial cancer. I hope I've convinced you biomarker testing is the way to go. At the bare minimum, utilizing mismatch repair deficiency testing to really understand what therapies your patient has, as well as determine if she might have a genetic syndrome that's contributing. When you do find that patient with microsatellite instability, high disease, single agent checkpoint is the way to go. If the patient has microsatellite stable disease or microsatellite or mismatch repair proficient tumors, that's where we're looking at the combination of pembro and lenvatinib, and to be determined over the next few years if some of these agents get to move up into the upfront setting. And then we're going to be working through how to determine should we use chemotherapy versus combination strategies. And then we need to be prioritizing clinical trial enrollment so we can continue to change the standard of care and provide the best outcomes for our patients. And we really need to work on understanding what the barriers are for diversity within clinical trials and try to overcome those barriers. And then finally, throughout this talk, I've spoken to you about patient education and making sure our patients understand the treatments that are being offered, understand the potential adverse events so they can make a good decision, and then also have the best outcome while they're receiving that therapy. So I just want to thank you all so much for joining us today. I think we've seen the evidence that supports the use of checkpoint inhibitors for the treatment of patients with advanced cancer, and hopefully learned some effective approaches for integrating them into clinical care. I've also reviewed some novel approaches that are underway, potentially representing some alternatives for our patients. Just remember, you got to garner perspectives from all team members of the care team to have discussions about treatment decisions that best fit the need of your individual patient, utilizing a shared decision-making approach. Don't forget, you can download the practice aids associated with educational activity as a resource for you, your staff, and your patients. And thanks again. We hope you found this activity informative and useful for your practice.
Thank you for listening. Download materials and complete the post test for instant credit at peerreview.com/GEP860. This activity is supported by independent educational grants from AstraZeneca, Eisai Incorporated, Karyopharm Therapeutics, and Merck & Company Incorporated.